Hi, Dr. Chris Porter here, speaking with Dr. Kathy Hughes about breast care and breast cancer. Thanks for joining us today, Kathy. Please tell us a little bit about yourself.
Hi, I'm a general surgeon in private practice in Massachusetts, and the majority of my practice has been breast care and in addition to general surgery, so that's why we're here today.
Indeed. Can you tell us a little bit about what the data about screening mammography and what we've been learning? There's been a lot in the popular press, and I'm curious how it sort of sorts out for people in the profession.
Well, there's been a little bit of controversy over the last couple of years, and I think what that teaches us is that evidence and the practice and the science of medicine isn't static, and we can't be dogmatic and pedantic about how we approach even something which seems as basic as screening mammography. And I think what the big article that we're dancing around, which is the report from the United States Preventive Services Task Force, what a mouthful, suggesting that women don't need to be screened until after 50 and only every 2 years, sort of created a furor in the breast care world, both on the surgical and the radiology side. And I think it's generated a lot more interest and focus on reviewing the numbers, reviewing the evidence and the data that we have, and looking back at where it has been and where it's going. So the data has continued to evolve, and where there was maybe some initial skepticism sparked as to how much of the improvement in breast cancer outcomes could be attributed to screening mammography versus just improvements in therapy and treatment. I think the evidence is now building again that screening mammography has made a difference, and nearly of the magnitude that we had thought before. And I think most data between 25 to 28% improvement in breast cancer mortality over time that you can largely base on the utilization of screening mammograms.
Mm-hmm. And was there a new body of data that just became available that led to the recent controversy?
Well, I think there's some, questions of the data out of Scandinavia where the population data is a lot easier to access, and mammography is more broadly done. But I think there are still many other studies before, during, and since then that have really spoken to the efficacy of screening mammography, both for, in the context of the population. And I think other evidence that shows that really mammography is still the gold standard as far as screening goes. Other technologies really haven't been able to step up and take the place of it.
Mm-hmm. And what organizations publish recommendations, and how have those recommendations changed over the past couple of years?
Well, the American Cancer Society is probably the best popularized out there in the media organization that sort of collates all of the sources and publishes data that the lay people as well as medical professionals access. The American College of Surgeons and the American Society of Breast Surgery also publish guidelines. The CDC publishes guidelines. And just even, re-reviewing the latest that's out there from the different organizations, I would say that the American College of Surgeons, the American Society of Breast Surgery, the American Cancer Society are pretty much in line with starting annual mammography at age 40. Sometimes it gets a little softened, at least every 1 to 2 years. Maybe the biggest difference, just to capture the population. the women that may have skipped a year, so they don't feel like, oh, I've skipped a year, I might as well give it up entirely, can be, no, every other year, if you still do it regularly, is good enough. So, there's been a couple recent studies I've seen even in the past couple of weeks that indicate that there may, still some data out there that it's worthy to screen that population between the ages of 40 and 50. You're balancing a little bit more of a difficult test to interpret versus what you gain by catching an early cancer in a younger age group. It tends to be more aggressive and those kind of things. So the data is still evolving, and I think it just speaks to the desire to continue to practice evidence-based medicine and have the body of evidence that you can point to and say, yes, this is why we do what we do. This is how this evolved.
Mm-hmm. And how do you think things are changing or have changed because of that latest report or data among primary care providers? Do you think they are sticking with the previous?
I think it's enhanced confusion. Because mind you, as somebody who takes care of a lot of breast patients, I'm still the consultant and the specialist. So I'm actually, though I'm extraordinarily opinionated about how this should be done, as any good surgeon is, I'm not really the one that's ordering a test. So I'm in the position of educating patients as well as providers, nurses, and physician colleagues on things as basic as what is the difference between a screening mammogram and a diagnostic mammogram? Why do you do it? What do you do when? At least here in Massachusetts, women don't need a doctor's order to get a screening mammogram, and sort of getting that out there, that the patients, even if they haven't seen their doctor, can still do this. I would say the other side of that coin is making sure they have a doctor so that if they do get a result, that it goes somewhere. So if God forbid something were found, it doesn't get lost fall in the cracks. So I think, getting the word out to the primary care doctors that that a regular screening program is still important. I think that data is a little fuzzy about the endpoint, like when do you stop? And I think that hand in hand with screening is also doing risk assessment and encouraging the primary care physicians and nurse practitioners who are seeing patients on the front lines to at least have in the back of their mind some way to assess breast risk, even if they're not doing a formal calculation, to put things in context, to help them validate in their own mind and for the patients they're caring for how best to deploy a screening strategy.
Okay. So,
some women may balk at it annually, but agree to it every other year.
Okay. So the overall picture for all that stuff that came out in the mainstream press was that it hasn't really changed what people practicing within the specialty of breast care recommend. Is that the case?
I would say, yeah, pretty much.
Okay, very good. So what else would you like to say about mammography and the recent data?
Well, I think it's important to just make sure that whether it's annual or every other year that physicians should try to get their patients on a regular schedule, because you look at some source data that comes out of the National Cancer Institute and the sort of population statistics, where you look at what percentage of women are getting mammograms every year or every other year, and how that breaks down by socioeconomic or ethnic background. And even, the highest screened population of, high school and better educated Caucasian women is still 75 to 78%. So that's, in my book, a pretty significant chunk of the population that isn't getting screened in the most highly screened population. And then lower socioeconomic level, lower education level, and depending on ethnicity, that number can dip as low as like 48%, which speaks to some disparities. And that unscreened population still presents with cancer. And so their numbers still feed into the numbers of the impact of screening or not on our whole population.
Oh, interesting.
And I think it can really muddy the waters. So, I think, statistics can paint interesting stories, but you have to put statistics in context. There's a joke recently that was apropos to me and a cousin of mine. She's a research biochemist. And the joke goes, a chemist and a biologist were out hunting with a statistician, and they see a deer, and the biologist shoots and misses 5 yards to the left. The chemist shoots and misses 5 yards to the right. The statistician goes, "Hey, we got it." So
good. Very nice. Well, thanks for talking to us today. I look forward to talking again on another topic. We'll talk about breast care in the elderly soon.
Great.
Thanks, Dr. Hughes. Bye-bye.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook, follow us on Twitter, and find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.